Our topic will be evaluation and imaging of the paranasal sinuses. So to start with the welcome address and introduction of the expert will be given by Dr. Our Shubhamoy Chakraborty, our President NEBAOI, Dr. Ravi Meher, Director Professor, Head of the ENT, MEMC, New Delhi is our expert. So Dr. Shubhamoy, please.
Thank you, madam. Good evening to all. Today we are conducting our 9th year NEBAOI classroom, and I welcome our external expert, Professor Ravi Meher, Director Professor and Head of the Department of ENT and Head and Neck Surgery, Maulana Azad Medical College, New Delhi. He's done his FRCS from Glasgow, FSCS and MNAMS. He is a member of International Working Group of Endoscopic Ear Surgery. He is a governing body member of AOI, ex-president Delhi AOI, ex-honorary secretary Delhi AOI, executive member National AOI, editorial board member All India Rhinology Society, international advisor RCPS Glasgow, editorial board member of Indian Journal of Otolaryngology and Head and Neck Surgery. Sir has got more than 200 publications in various national and international journals, and he is the author of Textbook of ENT and Head and Neck Surgery, 2023, that has been published. He has been awarded Indian Society of Otology Travel Fellowship in Advanced Otology in 2011, Kozia Ear Clinic, France, awarded UGC Travel Grant AOH NFS SF USA 2012, Best Teacher Award from MAMCOS, September 2014, Gold Medal Poster Session in AIRS Conference Udaipur, First Prize in Poster Presentation in AYCon 2010, Vishisht Chikitsa Ratan Award by Delhi Medical Association, Corona Warrior awarded by Delhi Legislative Assembly, First Prize in Quiz Competition at Haryana AOI Conference 2007, First runner-up in Dr. Prem Kakkar Bhatin Quiz held during the 53rd Annual Conference in Association of Otolaryngologists of India, PGI Chandigarh, January 2001. Second prize in ENT Resident Quiz held during the 28th Annual Conference of Association of Otolaryngologists of India, Delhi State in May 2004. So with this, I again welcome Professor Ravi Meher, Head of the Department, Director Professor of ENT and Head and Neck Surgery, Maulana Azad Medical College, New Delhi, for today's NEBAOI classroom. Thank you so much, sir.
Thank you very much, sir, for the kind introduction, and very happy to join this webinar. Thank you very much, sir.
Thank you. Thank you.
Thank you, sir, for coming. Today, our speaker is Dr. Krishanu Rudrapal, third year PGT, Sikkim Manipal Institute of Medical Sciences, and he will be introduced by Dr. Anjan Bhuya, our secretary, honorary secretary NEBAOI. Dr. Anjan, please.
Thank you, ma'am. Respected President, sir, and Dr. Ravi Meher, sir, and all the dignitaries who have joining in this session of scientific program. So this is the 9th program in this year, and this is 28th program at a stage, if you include the last year also. So in our today's program, Dr. Krishanu Rudrapal, who will be delivering his lectures. So he is a third year PG in the Sikkim Manipal Medical Institute of Medical Science, Sikkim, and he had experience of 3 years junior residency in Sikkim Manipal in the neurosurgery department. So he did his MBBS from Agartala Government Medical College in 2020. So I welcome Dr. Krishanu Rudrapal, and my best wishes to you for your deliberation.
Thank you, sir.
Thank you, Dr. Anjan. And next, our introduction of the moderators. Our moderators are Dr. Rupanjita Sangma and Dr. Kaustubh Kalita, and they will be introduced by our Dr. Hiranya Bora, who is Chairman, Scientific Committee.
Good evening, everyone. So let me introduce our today's moderator, Dr. Rupanjita Sangma, and Dr. Kostap Kolita. Rupanjita Sangma, she is a professor and head Department of ENT, Nagaon Medical College, Assam. Award and achievement, she did post-graduation from Guwahati Medical College at 2008, and she received S. Kumar Award by NEBAOI. She was editor of NEBAOI Journal from 2018 to 2024. She organized FACE workshop and temporal bone hands-on workshop in Assam Medical College. Her many presentation in national and regional conferences. Her publications, there are more than 20 publications in international journal. She is a member of AOI, NEBAOI, Aesthetic Society of Northeast India. Now, let me introduce Dr. Kostap Kolita. Dr. Kostap Kolita, he did MBBS from Assam Medical College in 2006, DLO from Assam Medical College 2009, and DNB from KKR ENT Hospital, Chennai 2012. He worked as consultant ENT surgeon at KKR ENT Hospital till 2018. He is a consultant ENT surgeon at Ayushanda Hospital from 2018 to 2022, and he is presently working as consultant ENT surgeon at Apollo Excel Care Hospital, Assam. Thank you, everyone.
Thank you, Hirana Madam. So, Dr. Kishano, you can start your presentation.
Okay, ma'am.
Your time is 30 minutes. Everybody mute yourself.
Good evening, everyone. I am Dr. Krishan Rudropal, postgraduate in Department of ENT and Head and Neck Surgery in Sikkim Manipal Institute of Medical Science. Today, I will be discussing regarding the evaluation and imaging in paranasal sinus diseases, its approach to the nasal obstruction epistaxis, and CT scan for the paranasal sinuses, a diagnostic workup of the sinus disease, and ending with the indications of the surgery. So first of all, the outline of my presentation is, firstly, I'll be discussing regarding the nasal obstruction, some basic regarding the adult and the children who are having different kind of nasal obstruction, either the laterality or the causes of the nasal obstruction. After that, I'll be discussing some regarding the anatomical basis and the patients who come to the OPD with epistaxis, how to manage them, and the use of the CT imaging or the radiological imaging in case of paranasal sinus diseases, and the closed surgical checklist, along with the sinus disease workup for the diagnostic nasal endoscopy, and to help in the multinodal workup strategy, and then ending with the surgical indication, the criteria that are needed for the functional endoscopic sinus surgery in chronic rhinosinusitis, polyposis, or any emergent complication, and combining with all this will be a summary in the final consideration for the pre-operative optimization and patient outcome. So let us begin with the nasal section, which is mainly the gateway to the sinonasal evaluation. So first of all, what is a nasal obstruction? It's mainly one of the main chief complaints that we find in case of a nasal pathology. So due to that, it can be either subjective or objective. So either the patient might be telling there might be some obstruction which cannot be seen, and there might be something which can be seen by the clinician, and we can go for a objective one. So it's for us to know, is it a subjective case or objective case, and primarily patient will be discussing it as a congestion of the nose. There might be some blockage due to any of the reasons. So if there is anatomical obstruction, there might be some septal deviation where you can see deviation of the nasal septum. There might be hypertrophy of the turbinate. There might be some masses, any sinonasal malignancies can also occur. There mucosal diseases like inflammatory rhinitis or chronic rhinosinusitis with or without polyposis. Along with that, some sensory disperception can happen in case of empty nose syndrome or in case of atrophic rhinitis. So we go for the nose scale, which is with the grading is there from 0 to 4 with no problem to the severe problem. We can grade it and we can rate the degree of the nasal obstruction, which is over the past 1 month. Now, few key points that need to be taken in case of going for the clinical history of the patient is the duration and the frequency of the nasal obstruction. Either it's a unilateral or a bilateral, or if it was bilateral also, did it start with unilaterality and then it went to the other side and became a bilateral. So in case of duration and frequency, we'll go for, if it's a duration is constant, the frequency is a constant, then we go for anatomic variation in the nasal obstruction. It might be intermittent, which can be diurnal or diurnal variation, which can be mucosal or allergic, or it can also be vasomotor rhinitis. So in case of a laterality, so in case if it's a child, then unilateral obstruction should always be suspected as a foreign body, and otherwise until otherwise proved anything. And in case of adult also, in unilateral obstruction, in a constant unilateral obstruction, it's a red flag sign, because sinonasal malignancy can mimic in this case and can be proven by endoscopy or any other radiological imaging. Then sometimes patients come with complaints of nasal obstruction, which might not be any pathological, mainly a physiological, which is a normal congestion and decongestion of the nasal mucosa that due to venous congestion of the inferior turbinates. So there can be physiological congestion which might change from one side to another side in every 2 to 7 hours. So mainly the patient need to be educated regarding these cases, so that they get the problem. Sometimes the problem might not be there, but the nasal cycle, the physiological problem might be explained so that they can understand better. So in case of in some of the objective testing can be done in case of nasal obstruction is our rhinomanometry. As the name suggests, we need to use air pressure to know the functional assessment of the nasal. Sorry, the functional assessment of the nostrils. So measuring the resistance, the rhinomanometry is measure the relationship between the transnasal pressure and the air flow during the breathing between the both the nostrils. So it can be different type. It can be active anterior, it can be positive anterior. So the most commonly that is used is active anterior, which is the most common, and it measures the each side separately. There is a equation also in which derived from the Ohm's law, where resistance equal to pressure by the volume of the airflow inside. So here you can see a sigmoid curve characteristic of normal nasal airflow and showing increasing resistance at a higher flow rates. So it's mainly useful in case of a pre and post-operative assessment of a nasal surgery, mainly in septoplasty or turbinate reduction, which will help us to know regarding the functional obstruction in the nose, and will also help in assessment of the post-operative status of the nose, post-operative status of the nose also. And another method of knowing the patency of the nose is your acoustic rhinometry. As the name suggests, sound waves will be used in this case. So we will know the structural anomaly in case of acoustic rhinometry. So it will be using the sound reflection to map the cross-sectional area of the nasal cavity as a function of distance. So there are two things that we find out in case of acoustic rhinometry. One is the I notch and another is the C notch. So the I notch mainly the sound reflection that is measured in the isthmus or the nasal valve area, and the C notch is mainly in the concha area or the anterior part of the inferior turbinate head. Then the diagnostic value is excellent for identifying the anatomical stenosis, and also helps us in quantifying the effect of the decongestion. So we can use the we can do a acoustic rhinometry of the patient, and following a decongestion use, we can see the change in the anatomical obstruction of the nasal cavity. So after the measurements of the objective measurements of the nose, we'll go next to the epistaxis, that is the anatomical basis and the management algorithm in case of a nosebleed patients. So, as you all know, regarding the anatomy of the nasal blood supply, one of the main thing that we find out is the Kesselbeck plexus, also known as the Little's area, present mainly in the anterior-inferior area of the nasal septum. So here the picture shows there are multiple blood supplies along with the anastomosis that can be seen in the nasal septum. So main arteries that are involved in the Kesselbeck plexus are the artery of epistaxis, the sphenopalatine artery, along with the greater palatine artery, superior labial artery, and the anterior ethmoidal artery, in which in the nasal supply, the posterior ethmoidal artery is not in the part of a Kesselbeck plexus, and sometimes posterior epistaxis or posterior bleeding is seen in case of Woodruff plexus, which was mainly research was done regarding Woodruff plexus. After the upcoming of the endoscopy, it has been seen that it's one of a venous plexus that is situated in the posterior part of the inferior turbinate, which is also a area for bleed in case of adult case, in case of old age patients. So epistaxis management algorithm, mainly the first one is the initial management, which you know, that is your ABC assessment. Nowadays it has changed into CAB, that is circulation has been given to the first priority. So once the patient comes to us regarding a epistaxis case, we'll go mainly for a tortoise maneuver, where the patient is counseled to pinch the nose and then to bend forward and wait for around 5 minutes, so that the compression can help in stopping the nosebleed. And to add it to that, you can also use some cold packs or ice packs, which are the initial management for the case of a dyslexia patient. Now some direct approach is, once we have find the patient, after the initial management, we can go for suction of the nasal cavity under endoscopic visualization, and we can go for cauterization of the part if we find there is a specific bleed that can be seen in the nasal septum or in the inferior turbinate area or any other area in the nasal cavity. So we can use the silver nitrate or the bipolar cauterization, or sometimes we can use 10% trichloroacetic acid also for the cauterization of the epistaxis part. Then even if that also doesn't work, we can go for tamponade, that is mainly the anterior nasal packing or the posterior nasal packing, which is done, and the patient is kept for around 48 hour to 72 hour in observation. Mainly in case of posterior nasal packing, the admission is required to check to follow up the patient and to check for any nasopulmonary reflex or any hypoxia in the patient patient might develop due to the posterior packing. So the patient can also be kept in the hospital for observation. Then even if that doesn't work out, we can go for the surgical aspect, that is ligation of the palatine artery, if that is the one which is bleeding, or you can go for any other artery which are mainly the other than the spinopalatine artery. You can go for the anterior ethmoidal artery if that is the cause of the or the source of the bleed in case of epistaxis. Now, regarding anterior nasal packing, mainly it is indicated when local cauterization failed or the site is not identified, or we are suspecting that the bleed is from the anterior part, that is anterior to the piriform aperture. If the bleeding is from the piriform aperture, in the modern clinical use, we have seen use of carboxymethyl cellulose also, which are mainly known as Merosil or uh, Rhinopro, which can be used in case of anterior nasal packing, and also sometimes posterior nasal packing can also be done, which mainly requires admission and monitoring. Sometimes nowadays, sometimes we can use Foley's catheter or specialized balloons if the posterior nasal pack is not if the posterior nasal packing is not done properly, or if there is if there is unavailability of doing any posterior nasal packing, we can directly use the Foley's catheter or some specialized balloon in case of to stop the bleed. But in case of posterior packing, we need to know that we need to monitor the patient and monitor for hypoxia or any nasopulmonary reflex which may activate the vagus nerve and can cause bronchospasm of the patient. Now the ligation techniques that we use, even if the anterior or the posterior packing fails, so what we do, we mainly go for the anterior posterior packing, keep the patient for 48 to 72 hours, the pack in the we keep the pack for 48 to 72 hours in the nose, and then we open it up, and we mostly find that there is no bleed, and we can treat the patient accordingly. But sometimes there are in cases there are 40 to 50% also cases we might see rebleed. So in those cases of the rebleed, we can go for the ligation techniques of the sphenopalatine artery, the main artery. Otherwise, we can go for even if the sphenopalatine artery is not been, if you cannot ligate it, then you can go for the, or even if the after the ligation, if there is bleeding, we can go for the ligation of the internal maxillary artery, and then next we can go for the external carotid artery. And if you find the bleeding is from any other artery, that is anterior or the posterior retinal artery, you can also go for ligation of those arteries also. Next, this is the photo of a rotable ligation clip applicator that is used in mainly endoscopic, say, sphenopalatine artery ligation. Here, next, we can see the photo where the hemostatic clips are used in case of sphenopalatine artery ligation. Now the management strategy, as we have discussed before on. So mainly the initial part, we will resuscitate the patient. If there is heavy bleeding and all, we'll try to resuscitate the patient. If there is a normal, according to the amount of the bleed, if it's scanty or moderate, we'll try to reassure the patient and we'll go for an initial examination. So in the initial examination, there will be two kinds: either the vessel, that the bleeding vessel will be located, or the bleeding vessel won't be located. If the bleeding vessel is been located, it will be very good for us. We directly go for bipolar therapy. Sorry, we'll directly go for any cauterization therapy. Either it will be bipolar, we can go for silver nitrate, or we can go for 10% TCA solution, also 10% acetic acid TCA solution also. Then if the vessel is not located, we can go for next is endoscopy. If the vessel is still not located, we can go for an indirect therapy, that is your anterior pack if there is anterior bleed, or you can go for a posterior pack if there is a posterior bleed. Then if the bleeding continues after even after 48 hours, we can go for the posterior peg, suspecting that it's a posterior bleed. Then you can go for some septal surgery or any ligation. Then even if there is a continued bleeding, then you can go for angiography and embolization of that specific artery, and you can repeat the above steps and check for any other secondary factors. So either it's a primary epistaxis or the secondary epistaxis. Even if it's a secondary epistaxis, we need to treat the secondary factors also and the secondary cause also, which are causing the nasal bleed or the epistaxis. Next comes mainly the roadmap for any paranasal sinus surgery. That's the radiological findings or the radiological imaging, that is computed tomography, CT scan of the paranasal sinus, radiological anatomy, and the surgical navigation in case of endoscopic sinus surgery. So here I'll be showing some cut section of the photo of CT scan from the from the caudal to the cranial part. Here, in the first CT scan, we can see the first cut section. You can see that the anterior nasal spine can be seen. As you go up, we can see the greater palatine foramen along with the lesser palatine foramen, and then you can see the posterior nasal spine there. Along with that, as we go up, we can find the anterior and the superior alveolar canals and the posterior alveolar canals, and the descending pterygopalatine canal can also be seen just behind the maxillary sinus. Then we can see the coronoid process, lateral pterygoid plate, the medial pterygoid plate as we go up. Then the frontal process of the maxilla, the cartilaginous nasal septum can also be seen. The infraorbital foramen can be seen. Then along with that, next we can see the zygomatic recess, the palatine recess, the inferior turbinate can be seen extending from the anterior to the posterior, along with the inferior meatus, which is just the lateral to the inferior turbinate. The piriform aperture can be seen just so the anterior to the bleeding anterior to any part of this piriform aperture will be called as the anterior nasal bleed, and anything that is posterior to the piriform aperture will be called as the posterior nasal bleed. So we can see the posterior choana. Along with that, the infraorbital canal, the zygomatic arch, the sphenoid spine can be seen. Along with that, in this one, we can see the sphenopalatine foramen, which is mainly entry point for the sphenopalatine artery and veins, along with the second branch of the trigeminal nerve, giving the nasociliary branch to the nose from the fifth cranial nerve, the trigeminal nerve. Then you can see the pterygopalatine fossa, the pterygoid canal or the viridian canal. Along with that, the foramen ovale and the foramen spinosum can also be seen. The horizontal petrous carotid canal can be seen running can be seen in this part. running, and the auditory tube can also be seen. Next here you can see the main points of the paranasal sinus is the middle turbinate, the uncinate process, the middle meatus, the infundibulum, which the hiatus semilunaris, which all consist of the osteometal complex, the one of the main functional area of the paranasal sinuses, where the anterior paranasal sinuses drain. And along with that, you can see the superior turbinate. Sometimes if there is a presence of supreme turbinate also, we can see the sphenoethmoidal recess can be seen. Then sometimes if there is a presence of any space above and behind the ethmoidal bulla, we can see as a supraethmoidal or the retroethmoidal cells can also be seen. Then right sphenoid sinuses, intrasinus septum, the left sphenoid sinus. Then anteriorly we can see the lacrimal bone along with the agar cells, the anterior ethmoid sinus, the basal lamella can be seen, which is one of the main identification point in case of a endoscopic sinus surgery. The posterior ethmoid sinus, the sphenoid ostium, and also the vertical lamella of the middle turbinate. And then here you can see the anterior lacrimal crest along with the lacrimal sac fossa can also be seen. The posterior lacrimal crest can be seen along with the vertebral limb of the superior orbital fissure. The vertical attachment of the middle turbinate can be seen, as there are three attachment for the middle turbinate. So here you can see the vertical attachment of the middle turbinate. There is one attachment to the basal lamella, one to the lamina preparation, and one to the skull base. Here you can see the frontal recess. In this picture, we can see the optic canal, which is sometimes if there is a presence of any posterior cells like onody cells, we need to take care regarding in case of surgery where the optic nerve along with the intracarotid artery might be visible. In case of any endoscopic sinus surgery, if you want to go for the posterior, if you want to go for the posterior ethmoidectomy, or when we want to go to the sphenoid sinuses, so we need to take care of this part, the optic canal. Along with that, we can see here the posterior ethmoidal foramen, the lateral limb of the superior orbital, the anterior clinoid, and the dorsum sella. Precellular carotid canal can also be seen in this CT scan section, and anterior ethmoidal foramen can also be seen. So one of the most common structure that we need to identify in case of a CT scan, which then one of the reason also why CT scan is most probably preferred over the X-ray, which was previously we used to go for the X-ray of a PNS. Now it has been evolved and developed to go for the CT scan of the paranasal sinuses. So the osteometal complex is mainly the final common pathway for all the anterior group of sinuses, for drainage pathway of the anterior group of sinuses. So the functional unit where the frontal maxillary and the anterior ethmoid sinus drain. So the main structures of the osteometal complexes are uncinate process, then ethmoidal bulla, hiatus semilunaris, then infundibulum. Other than that, there are other structures also which make there are total 7. Other than that is the maxillary ostium, the middle turbinate, and the middle meatus are also included, which the 7 of them with along with all this all these 4, the 7 of the component comes and go for named as a osteometal complex. Then some of the variations that we can see in case of CTPNS, in case of the CTPNS, where we can find concha bullosa, that is the pneumatized middle turbinate, a common variation where the middle turbinate consists of air cell. So here we can see here you can see the presence of the concha bullosa. Then which may as the size of the middle turbinate increases, so eventually the nasal cavity, the size of the area of the nasal cavity will also decrease. So this may lead to narrowing of the middle meatus also. Along with that, if this is symptomatic, it might cause obstruction or sinusitis, and it can be a surgical indication for removal or even for a bullectomy, the part of the bulla that is obstructing the sinonasal pathway. And we need to mainly differentiate sometime between the bent middle turbinate or the paradoxical middle turbinate compared to the concha bullosa of the middle turbinate. Then few air cells which need to be identified is the Heller cell, which is also known as the infraorbital ethmoid cells, which can be which is located in the floor of the orbit. So there might be a large Heller cell which can obstruct the maxillary ostium, and then we need to take care regarding any endoscopic sinus surgery regarding this Heller cell, the presence of the Heller cell, and also the Egernsey cell. So Egernsey cell is one of the most anterior ethmoid cell that can be seen just anterior to the axilla of the medial turbinate. So it is found in the lacrimal bone and one of the main key landmark for identifying the frontal recess. So we need to remove the Egernsey cell if we want to go for any surgery regarding the frontal recess, that is a draft surgeries. So we need to remove, or if you want to identify the frontal recess, we can also need to remove the Egernsey cell so that we can see the frontal recess area. So here we can see the area where so here you can see the area where the just below the frontal recess there is the presence of the Egernsey which is obstructing the frontal sinuses. So sometimes it might be required to remove the Egernsey so that the frontal sinus drainage pathway is cleared out, and any pathology in the frontal sinus can be cleared out. Then another surgical danger, as I was discussing earlier, is the sphenoethmoidal cell, also known as the Onodi cell, which is the most posterior ethmoidal cell that pneumotizes superior lateral to the sphenoid sinuses. That's why mainly when you go for the opening of the sphenoid sinus, we try to go more medially rather than going more laterally, due to might be present and also might be injury to the optic canal and also injury to the internal carotid artery. So here you can see a CT scan showing the presence of the Onodi cell just superlateral to the sphenoid sinus in case of a left sphenoid sinus. And the optic nerve and the internal carotid artery are often exposed in these cells. So that's why it's very important in case of any functional or any endoscopic sinus surgery to know if there is a presence, or if there is a presence of any Onodi cell just before the surgery. So it's very crucial for the surgeons to identify to avoid the blindness or any hemorrhage. Now, regarding going before any surgery, we need to know regarding the Keros classification. That is the depth of the skull base, which has been divided into three groups, that is 1, 2, and 3, the type 1, type 2, and type 3. So it mainly measures the height of the lateral lamella of the cribriform plate. So this is the most why? Because this is the most thinnest area in this part of the lateral lamella. This is the most thinnest area, but so which can be breached in case of any endoscopic sinus surgery, and can finally present as any encephalocele, which might cause some further complication to the patient. So we need to know the depth of the skull base. So if the most safest is the type 1, which is mainly 1 to 3 millimeter, the risk is very low. So if you go, the more the depth is, the more is the risk. So the type 2 is 4 to 7 millimeter, is a medium risk, and the type 3 is the most with the maximum depth of 8 to 16 millimeter, which can go for the highest risk. So and regarding the new advancement also, that has been a fourth type has been given, which is mainly called as asymmetrical, which might be both the side might not be symmetrical, so that has been classified as a asymmetrical type. So the type 3 has the thinnest bone and the highest risk of iatrogenic CSF leak case, and also in case of any encephalocele, which or any meningocele, in case of iatrogenic meningocele, which can cause some other further complication to the patients. So regarding going for a functional endoscopic or a endoscopic sinus surgery, we need to check out for the close algorithm. So what is close algorithm? Mainly the C goes for the cribriform plate or the Keros type or the Keros classification that I just discussed in the earlier slide. Then along with that, we need to know for the lamina praepacia if there is any dehiscence on the lamina praepacia, or if there are any dehiscence following any post surgery of the paranasal sinuses, or the presence of any Onodi cell, so which can cause any optic nerve risk. Then the sphenoid or any variation of the sphenoid sinuses, or there is any the septation of the sphenoid sinuses. then location of the ethmoid artery. So there is a there is an area in the CT scan where you can find the presence of the anterior ethmoid artery, also known as the nipple sign, which we can see and can identify the presence of the presence and the location of the ethmoid artery before the surgery through the CT scan. So, and then last is the stop is to reevaluate if there is any high risk landmark. So this is the mainly the close algorithm. So once the close algorithm is been cleared out from our side, we'll go for some other diagnostic workup of the sinus diseases. So mainly these are the workup which are beyond the radiological imaging. That is mainly we go for the SNOT-22 quantification. That is a standardized assessment for the sinonasal outcome. It is one of the most gold standard for assessing chronic rhinosinusitis or the impact of the chronic rhinosinusitis to the patient. Mainly covers the physical, emotional, and the social impacts. So a score reduction of 8.9 is considered the minimal clinical important. So here is the sinonasal outcome questionnaire, where you can see there are 22 points and given with 0 to 5 marking. So after going for a thorough questionnaire to the along with the patient, we can find out the problem of the patient, and we can after finding the total point, we can go for the what is the problem of the how much is the problem of the patient. If it's a case of a very mild problem, moderate, severe, or the problem is so bad that the patient might need some intervention as soon as possible. Other than that, the other imaging part which we do mainly in the outpatient basis or the OPD basis, that is the diagnostic nasal endoscopy. So here we can see the mainly so here you can see the one of the photo of a diagnostic nasal endoscopy. Here you can see the nasal septum, and then the medial terminate can be seen here. Then here is the inferior turbinate. So this is the floor of mainly the floor part, which is the first pass, which we call. So there are three passes three pass technique that we consider in case of a diagnostic nasal endoscopy. The first one is the along the floor, which we see the along with the floor, that is you need to see the inferior meatus part, the floor part, and along with that the nasopharynx area. Then we go for the second pass, that is just medial to the middle turbinate. If you consider if this is the middle turbinate, so this part is the main part which you see for the second pass. So in the second pass, we'll go for the sphenoethmoidal recess, so mainly the drainage part of the sphenoid sinus or the posterior ethmoidal sinus. So we'll see that area. And the last, one of the most important part, which is the third pass. Third pass is being this part where we need to see the OMC area or the middle meatus area. We're looking for any pus discharge or any polyp or any edema in that area that might be causing any obstruction to the drainage of the pathway, drainage of the sinus pathway. So here is on the video where we'll see this is the deviation of the nasal septum. We can see the nasopharynx area here. Here we can see only the one pass only. So few of the abnormalities which you might find in case of a diagnostic nasal endoscopy. So here is the deviated nasal septum. Mainly, it's the type of the DNS. We call it a spur, a self-ray projection which is projecting out from the nasal septum. So or you can find any foreign body, as in case of in our OPD we found out a leech which was on the causative, which was causing epistaxis for 1 week in the patient. So some other foreign bodies can also be seen mainly in case of children. Unilateral nasal obstruction, a foreign body should always be ruled out. So in nasopharynx, we might find some findings in the nasopharynx as we go for the first pass. As in our OPD, we found out a thorn wall cyst in the nasopharynx, which was also an accidental finding. Then in case in the middle meatus area, we might find any polypodal mass arising from the middle meatus area or also from the sphenoethmoidal recess area. Then some sinonasal malignancy cases, like you can see this case of inverted papilloma case. So these cases can also be seen once we do a diagnostic nasal endoscopy. So diagnostic nasal endoscopy also helps us in assessing helps us in assessing, also giving us a picture of the pathology, all the local or a local inflammation, local pathology of the nasal cavity. So which will be very helpful for us in managing the patient and also for surgical in the post-surgical cases. So in the DNA finding, the endoscopic staging of the nasal polyp is so either it can be graded into three: 0, 1, or 2. Absence of the polyp in the middle meatus only, or it is beyond the middle meatus. So some points which can also be seen is edema, discharge, scarring, and also crusting of the nasal cavity. So mainly the grading helps us in checking the disease progression and also the response of the corticosteroids. So radiological finding, which will be compared with the grading of the polyp, is the radiological status of the CRS, paranasal sinus. So if the maxillary is involved or not. So the maxillary is involved or not. Along with that, anterior ethmoid, posterior ethmoid, sphenoid, the osteometal complex. So everything will be considering for a certain amount of points, and after the points, we will be going for the grading of the radiological grading and also the staging of the chronic rhinosinusitis. So some laboratory and functional assessment can also be done in if you are suspecting for a patient who are mainly the allergy case, we can go for skin prick test or for immunoglobulin E also. So it's mainly crucial for managing the allergic rhinosinusitis. So as we need to know the value of the IG also, so we need to counsel the patient post surgery that might be a risk of reoccurrence also if the patient comes to the contact with the allergen or if there is an increasing IgE amount in the patient in case of a post surgery. So in immunology case, we need to know the total IgE, the IgE subclass. If recurrent infection is there, we need to rule out these immunodeficiencies. Then olfactory testing can also be done, the upsit or the snip stick, to quantify the amount of hyposmia of the patient, which is mainly common in the chronic rhinosinusitis with nasal polyposis. So after discussing all this imaging and the imaging and the assessment of the sinonasal part, there are few indications we need to keep in mind before counseling a patient for the need for the surgery from our side. So now I'll be discussing regarding the indication, goals, and the success criteria regarding a functional endoscopic sinus surgery. So one of the main indication for the surgery is our chronic rhinosinusitis with or without nasal polyposis. So the criteria for the functional endoscopy rhinosinusitis surgery is if the surgically is really the first step. So we need to counsel the patient that surgery is not the first step and also not the solution for the disease or for the pathology. So the primary indication is if there is a failure of the medical management. So mainly the failure of the medical management, which even of the failure of the medical management, the patient is coming with the same symptoms, and we need to counsel the patient for the surgical part. So mainly the duration should be more than 12 weeks of the stay of the medical management. The symptomatic, the pain, obstruction or any discharge that is of the patient should not be relieved, and there might be failed to 4 to 6 weeks of topical steroids plus saline wash, or if the if and antibiotic is also used in case of any infection. So even if these three criteria is not full is done, and even if the patient is not getting any symptomatic relief, we might consider and also counsel the patient in case of need for any surgery, endoscopic sinus surgery or any functional endoscopic sinus surgery. So there are some cases where there might be some cases of emergency where we need to counsel the patient the need for emergency endoscopic sinus surgeries. That is, if there is a case of acute sinusitis which is going to cause complication according to the general classification grade 3. If it has caused the orbital cellulitis, then you can go for emergent surgical indication. Or if there is any spread of the infection to the intracranial spread of the infection, we can go for emergent surgical indication. Or if there is any case of invasive fungal sinusitis, for example mucormycosis, we can go for a emergent surgical indication. So any subperiosteal abscess, that is channel classification 3, causing proptosis or any vision changes, or any meningitis or brain abscess resulting from frontal or ethmoidal sinusitis, which breaching the frontal bone and the ethmoidal bone and going to the intracranial root. Or one of the most common surgical emergency surgical indication is the cause of invasive fungal sinusitis in immunocompromised patients. So some specific anatomical and pathological indications are mucocele, if there is a progressive enlargement of the any bony erosion or any orbital displacement. So if there is any intracorneal polyp, there will be typically requires a surgical excision as they do not respond to the medical management. Then some sinonasal tumors also like inverted papilloma, which can be done for endoscopic resection or can go for a medial maxillectomy in case of if it's a grade 1 only or stage 1 only, we can go for a medial maxillectomy. As the staging increases, we need to go for more of a open rather than endoscopic resection of the sinonasal tumors. Then in case of any traumatic or any CSF rhinorrhea, where you need to repair the skull base defect. Then in case of a dacrocystitis, after confirming with the ophthalmologist, if the obstruction is below the canthus area, then you can go for a endoscopic sinus surgery and endoscopic dacrocystal rhinostomy and open the area of the nasolacrimal duct, so there might be relief of the dacryocystitis. So the physiology of the functional endoscopic sinus surgery is mainly we need to explain the patient that it's not the just for example, just like cholecystomy, if we remove the gallbladder, it's not the end of the surgery or end of the treatment. We need to tell the patient that it's a case in which the patient has to be counseled that after the surgery is mainly done for the facilitation of the mucociliary clearance and also the facilitation of the medical management that was previously obstructed due to the anatomical variation or any other variations. So we need to improve the sinus ventilation, drainage as well, minimal disruption of the normal mucosa, widening of the natural ostia, allow the topical medication to reach the sinus cavity effectively. So what is the expectation of the surgery? 85% improve in symptoms for the chronic rhinosinusitis, lower in cases of Semter's triad. So post-op care is mandatory. Saline indications are mandatory along with intranasal and systemic steroid. So such surgery is often the half the cure. We need to counsel the patient repeatedly. Recurrence high in patients with extensive polyposis underlying eosinophilic inflammations. So the checklist that we need to know: always include endoscopy in first vision for unilateral symptoms. Move quickly from packing to surgical ligation in recurrent cases. Imaging CT is the roadmap. Use close algorithm to stay safe. Then reserve for patients who fail MMT or present with complications. And post-operative medical therapy is an important as the surgery itself. Thank you. That's from my side.
Thank you, Dr. Kishano. May I request our expert, Sir Ravi, please give your expert comments.
Dr. Krishna, it was a very nice presentation.
Thank you, sir.
Though you have tried to cover a lot of topics, because this 45 minutes is not enough for actually covering the whole radiology and clinical symptomology, even the epistaxis. And so it was there was a large topic which you have tried to summarize, and it was a nice presentation. I think you have covered most of the things.
Yes, sir.
But I would request, should I start with the comments, or we have two moderators also? Maybe they can start with the comments and
Sir,
questions, and
Sir, you
followed by,
can, sir, you can,
or I start with the comments. Whatever.
Sir, you
We'll
can
take the questions later.
Okay.
You please start with your expert comment.
So I've already said, it was a large topic, so everything cannot be covered in this small time. Otherwise, the presentation was good, and I know this presentation was actually made using AI, if I am not wrong. Isn't it?
Yes, sir.
No.
Yes,
You
sir.
use a lot of AI in these presentation, but I would suggest that you should be going through the standard textbooks rather than totally depending on the AI, because a lot of things actually have been missed in the presentation, which are very important. So, like for example, if you just go through this Scott Brown, that is a standard textbook for ENT, I mean, that is very important. Before making the presentation, you must consult our standard textbooks, not totally dependent on AI.
Okay, sir.
Thank you very much.
Thank you, sir.
So can we take the questions now?
Yeah, you can take. Rupanjana and Dr. Kostov, you can take the questions.
So Rupanjana, by the way, if you allow me, I can start off with the questions from the audience. Okay, so Fukan sir had mentioned that MRI was not mentioned. Uh, Before Ravi sir or the speaker says, just to second your opinion, sir, this is some topic when you talk about evaluation and imaging. I think it is really not justified to cover it in 30-40 minutes time.
Yes.
He has tried his best. I think it's not a bad presentation. So one question by Fukan sir, MRI was not mentioned. So uh, would somebody like to comment on it?
So should I comment, Dr. Riyansh?
Sir, actually, this is my son's name. I don't know. I mean, his
Acha,
laptop and his domain. So I'm Dr. Kostov, sir, actually.
Acha, Dr. Kostov. Sorry.
Yes, sir.
So can I comment on this MRI part?
Yes,
Yes,
sir.
yes.
Please go ahead, sir.
So MRI, is not indicated in routine case of CRS. So if you are suspecting CRS and you plan to do functional endoscopic sinus surgery, MRI is not indicated. MRI has specific indications, like if the disease is actually going into the orbit or there is an intracranial extension. So either you are suspecting some intracranial complications, you go for MRI. Also, MRI is indicated when you are dealing with sinonasal neoplasms, right? So because sinonasal neoplasm, the MRI gives you a better soft tissue delineation, so you can actually differentiate whether it's a mucosal thickening or it's a solid mass or it contains fluid, right? So there are different types of tumors and sinonasal malignancies which can be seen, and they can have intracranial as well as intraorbital extension. So in these cases, MRI is indicated. For example, if you just take a angiofibroma, if it is going intracranially and you want to know whether it is involving the carotid space, the carotid artery, or it is going into the cavernous sinus, and what is the extent of involvement, MRI is definitely better than CT scan, right? So these are the indications of MRI. Routinely, we don't get MRI for chronic rhinosinusitis patients. We get just a plain NCCT, but you have to get all the three cuts. So I just want to tell you something about the cuts. Like Dr. Krishna actually, did not mention about the coronal cuts. So coronal cuts are the most important cut, because what he showed is all the axial cuts. We should be studying the coronal cuts, which are more important, because when you do surgery, you are actually operating in the coronal cut from anterior to posterior. So it gives you an idea of the surgical plan, which can be seen on CT, right? So coronal cuts are more important, but you have to get an axial cut as well as sagittal cut to know the frontal sinus drainage pathway. It is very, very important to see the frontal drainage pathway, what is the thickness of the frontal beak on CT, and what are the cells which are in relation to frontal recess, the number of agar nasal cells, number of supra-agar nasal cells, and number of cells which are going inside the frontal sinus. Similarly, there are posterior cells like bulla ethmodalis, suprabullar cells, and interfrontal sinus septal cells. So these are important cells which must be seen on CT before you actually venture into the frontal sinus surgery. So that's all about that is all I can say in brief about the radiology of paranasal sinuses.
So I think the take-home message for the juniors will be like this. So if you're dealing with a CRS case, uh, NCCT PNS is the most important investigation. If you have any doubt of a pathology, which might be a neoplasm, it can be benign like an inverted papilloma, it might be a sinonasal malignancy, something which is going intracranial, up to the dura, you should be having an MRI with you. Now, I probably would like to add, sir, too much of intracranial extensions nowadays. Uh, there are people who say why neurosurgeon was not involved. So even small things can matter. So for the juniors, probably I would like to say that yes, when you're suspecting something, please MRI has to be added to your armamentarium. And that's it from my side. I think Rupanjita ma'am, if you would like to uh, take up any more
Yeah.
questions.
Okay. Thank you, Dr. Koster. Uh, Good evening, everyone. And Dr. Krishanu, it was a nice presentation.
Thank you, ma'am.
Though it is a very huge topic, of course, because you cannot, it's not possible to cover everything regarding evaluation of nasal diseases, but you did a good job. Just one question from my side. When do you feel to take a biopsy? Do you ever feel the need to take a biopsy?
Ma'am, in cases of if you are suspecting any case of malignancy, or if there's a case of uh, any unilateral obstruction, then we can go for the biopsy of the patient if it is indicated.
Okay, yes. And even if you feel that it could be a case of fungal rhinosinusitis, I think then also you
Then we
can
can,
go for
yes,
it.
ma'am. Along with the biopsy, we can send for the KOH mount and fungal culture
Yes,
if we
yes.
want to go
That
for.
would be your in the after your surgery you can send for
Yes, ma'am.
fungal, isn't it?
Fungal
Okay,
culture. Yes,
okay. Okay, thank you so much. It was a nice presentation. Once again, congratulations.
thank you.
So, if I am allowed, there is one more question from the audience. B.N. Sharma sir, management of epistaxis on anticoagulants. So I think that's a really interesting question. It's not been touched upon during the talk. So will the speaker be saying something, or we'll go to this? We'll go to sir directly.
So in case of management for the management of management
Camera,
of
Krishanu.
epistaxis. Yes, ma'am.
Krishanu, open your camera.
Ma'am, I opened this. Some problem is there. I cannot.
Okay, fine.
Go ahead. Go ahead.
Sir, in case of the patients are on anticoagulants, we need to first of all we need to remove the patient on an anticoagulant if we need to check regarding the risk and the benefit of the patient. If there is some cases in which the patient might be the anticoagulant that is going on is very much necessary for the patient, there might be some aneurysm or something else which need for the management of the patient. So we need to keep the patient in anticoagulants, and along with that treat the patient in case of epistaxis. We'll go for packing of the patient, and we'll go for if the patient is having high blood loss, we can go for blood transfusion also. Along with that, we can find out the area of the bleeding in case of endoscopic evaluation, and can directly go for cauterization, and or we can keep the patient under anterior nasal packing or posterior nasal packing or any other tamponade, so that there might be stoppage of the bleeding even after 48 to 72 hours, and then you can take it out and see the patient is if there is any cases of any rebleed or not.
Over to
What
you,
would
sir.
you prefer? What would you prefer in a case of epistaxis on anticoagulants, a nasal pack or Merosil?
Ma'am, I will consider anterior nasal packing more than Merosil.
Okay, but then the injury is also more
More.
with packing, I suppose. Okay, depends on how severe the bleeding is.
Yes,
We
ma'am.
can take the decision likewise. There's another question, the role of
Sir,
MRI in fungal diseases.
Let me,
sir,
if I'm allowed, Ravi sir, would you like to say something on this?
Yes. So
Anticoagulants with bleeding.
right.
Let me reframe my question. The people we see in the OPD with anticoagulants usually are referred from the cardiology part. Post PTCA, post CABG, other CAD cases, coronary artery diseases on antiplatelets, which combines either your aspirin, clopidogrel, or both. And if I'm not wrong, there is a usual pattern for this bleed, which is very, very easily identifiable right in the OPD. Most of them, I'm not saying all of them. So, your expert comments on this, sir.
So basically, if patient is on anticoagulant and patient is actively bleeding, I would not use a conventional nasal pack. The gauze pack and the ribbon gauze is very much traumatic it can cause lot of abrasion onto the nasal mucosa, and it will further bleed. It will further complicate the patient. So what I will do, I will either use, because if he's having some amount of ooze or active bleed, I will use a gelatin sponge, which is very, very soft, right? So it is just going to cover the nasal bleeding part, whatever the septum part which is bleeding. I will just put a gelatin sponge and let it be there and cause coagulation, right? So that is going to stop. Otherwise, if it is not stopping with even gelatin sponge, I will use a Merocil, which is smeared with good amount of antibiotic cream, sulforamycin or paraffin, because even as Merocil, if you try to insert dry, it can cause abrasion to the nasal mucosa, which is again detrimental for the patient. So very soft, gentle packing if the patient is bleeding. And I will also ask the uh, the cardiologist to stop, or maybe temporarily stop the anticoagulant if possible, or use minimum amount of anticoagulant, right? So there are things, there are like patient who is on warfarin, they can be or heparin, right? So heparin should not be used. Patient can be shifted on to other anticoagulants which are less likely to cause bleeding, or if they can be stopped temporarily, that will be the best thing, right? So that is how I am going to manage. And sometimes these patients will continue to ooze, some amount of bleeding will be there, but eventually it will stop. So don't be very aggressive in nasal packing in these patients.
So point well taken, sir.
Yes.
Any role of a cauterization if it's a small spurter?
So if there's a spurter, definitely you have to cauterize it. But generally, in these patients who are on anticoagulants, there is a generalized ooze. You will not find any spurter, right?
Only if there is a single spurter, sir. Generalize is the most common thing.
Right. So if there's a single spurter, you just go and gently cauterize it with the bipolar cautery, or maybe a silver nitrate stick. We generally use bipolar cautery. Silver nitrate sticks are not available easily, right?
Right.
Okay, then the next question was MRI in fungal diseases
Okay.
and then again invading type
All
disease.
right. So should I take this?
Yes, sir,
Yes.
please.
Again, so I mean, the indications are similar. Like if there is an involvement of the orbit, if there's involvement of the intracerebral cavity, definitely MRI can help you. And generally, if it is AFRS, then there can be a fluid. Basically, there can be uh, hypo-intense lesions, like, and there could be uh, calcium, these calcium deposit which are there, calcium magnesium deposit, they will appear black basically, right? And because they don't have water content, so it will depend on the water content of the tissue. And MRI can actually help you in differentiating whether there is a true invasion of the brain matter or not. Because invasive fungal sinusitis, there can be invasion of brain matter, there can be tumor, there can be fungal disease which can be going into the intracranial cavity, involving the dura, involving the frontal lobe. There could be abscess, micro abscess formation in the frontal lobe into the temporal lobe. So again, MRI has definite role in fungal disease when there is an intracranial involvement.
Okay, thank you, sir.
Yes.
Then there are some comments. We have to correct the coagulation profile, FFP, etc. Then
Yes.
another comment, yes, sir, regarding the epistaxis part. And then there's another comment, blood transfusion helps in epistaxis many times if required and also when other measures fail.
Yeah, so that we have to maintain the hemoglobin of the patient. That is very important. If the patient is bleeding too much, there is a low hemoglobin, then definitely we have to transfuse the. And in anticoagulants, if the patient is on anticoagulants, you have to stop or you have to modify the dose and decrease to the minimum dose. And in case patient is having hemophilia or blood coagulation disorders, in those cases we need to do infuse factors. So if there's a factor 8 deficiency, patient is having hemophilia, you obviously you have to start the patient on factor 8. and as soon as you give the factor VIII, the patient bleeding is going to stop. So in cases of coagulation disorders, hemophilia, Wilbrin disease, there are many other diseases which can actually cause epistaxis. In those cases, specific blood factors have to be given to the patient, or fresh frozen plasma have to be given to the patient to stop bleeding.
Super. Thank you, sir. There's
Okay,
another question. I
one
think
more question.
yeah,
Uh,
Dr. Costa, please.
if I may, by the way, which
Yeah,
nasal
sure.
dosing everyone prefers post-op first, especially Meher sir?
What is the question? Can you repeat, Dr. Costa?
Nasal dosing
Okay.
everyone prefers post-op first,
So,
especially you, sir.
yeah, so I mean, I am working in a government setup, so we generally ask the patient to make nasal douche on their own, and it contains basically sodium bicarbonate and common salt, the sodium chloride, right? Uh, but there are commercially available solutions like Naso Wash. These are basically they are tablets which are to be dissolved in around 2 pints of water, right? So approximately around 280 ml of water is taken in the squeeze bottle. So there's a squeeze bottle which is available with these preparations, and you dissolve that. The water should be lukewarm, right? Not very hot. It should be lukewarm water, and then you can actually use to rinse the nasal cavity on both the sides. And generally, this is good enough to loosen the crust and the secretions and the blood clots which are there in the post-operative cavity, and these generally get loosened out and they easily come out, right? Otherwise, when you try to remove these crust, they can cause epistaxis, they can cause bleeding, right? So nasal douching is very, very important after FES, and must be told to the patient. The method is also be important, right? So how to perform nasal douching is very, very important. And if the patient cannot afford these commercially available solutions, then we ask the patient to take 50 ml of syringe, and then uh, basically use 1 teaspoon of soda bicarbonate, that is the baking
Baking
soda,
soda.
yeah, and pinch of salt, chutki, that is that pinch of salt in 280 ml of water. And again, this can be used with syringe, 50 ml syringe. We give a 50 ml syringe to the patient, and he can douche on both the sides, right? And while douching, he has to say ka 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 ka, so that it actually doesn't go into the nasopharynx, right? And let the water come out from the same side, and it is going to release the crust which are dried up, the blood clots which are there, and the secretions which are there, right? So that is how it is advised. We generally don't ask the patient to put sodium biborate. The classical solution of nasal douche contains sodium chloride, sodium carbonate, bicarbonate, and sodium biborate. The sodium biborate is basically suhaga, so it is not very easily available. So we don't ask the patient to put suhaga, that is sodium biborate. We just ask the patient to give with saline and sodium bicarbonate. So that is how it is.
Sir, do you prefer using steroids in the nasal douche?
So we don't ask the patient to take steroids. We ask the patient to use steroid spray after the nasal douching. Once you have cleaned the nose, after that patient can put nasal steroid sprays morning and evening. Initially, we start BD doses, and then we can gradually decrease to OD doses. So again, it is very, very important that when you are doing FES, the polyps are removed, and you have a large complete ethmoidectomy should have been done, and the whole nasal cavity should be accessible to the nasal spray. So if you have not cleared all the ethmoidal air cells, then there can be problem, and the patient can have recurrences. So it is very important that you do a complete frontoethmoidectomy and spinodotomy and sinusotomy, and full house FES is important in these patients. And then the patient will be able to take the nasal sprays, and the nasal sprays will be able to reach the all the parts of the cavity which you have created inside the ethmoid sinus, right? So that is more important.
Sir, any comment on using budesonide douching?
So that has been, I mean, many people advocate budesonide dosing, but frankly speaking, we are not. I am not using it in our institution. We don't use it. We use nasal douching with nasal steroid spray, right? So steroid spray is very important post-operatively, and you have to type the disease. Very important. Typing, endotyping of CRS is very important. Like if the patient has type 2 disease, and that can be seen only on histopathology. Like if you when you are doing FES, you must send the mucosa from the middle meatus for histopathology, and if it is eosinophilic infiltrate, it is typed as type 2 disease. A patient who has a type 2 disease is very prone to develop recurrences. These patients will be on long term steroid spray. In fact, they will be on steroid spray for their whole life. They must do nasal douching, and they must be taking steroids for their whole life. And many patients who do not respond to steroidal spray or systemic steroids may have to be started on biologicals like omalizumab. These are the drugs, monoclonal antibodies, which are now available in the market, and these are actually useful for these type 2 patients only. But if the patient has non-type 2 disease, that means there is a neutrophilic infiltrate. These patients will not require long-term steroid spray, and they will be just okay after the surgery. So before taking the patient for surgery, it is important to type the disease, what type of disease patient is having. And this typing, endotyping, is very important, and it has been described by the recent EPOS paper on chronic rhinosinusitis. And I will advise all the trainees and the residents to please go through this EPOS paper, European position paper on sinusitis, chronic rhinosinusitis. It is available online, and you can easily download it. So please go through it, and you will be able to understand what is endotyping, how to diagnose endotyping, and how to manage the various type of endotypes.
So there's another question. If the patient is prescribed with steroid nasal rinses, do we still need to prescribe alkaline nasal douching? I think the
I
purpose
think it
of
is
both
very
the,
important.
yeah,
Alkaline nasal douching is very important. The purpose of alkaline nasal douching is to loosen the crust and the
trust.
blood clots and the secretions, right? So that is the purpose. But the purpose of steroid spray is to prevent recurrences, right? Because this patient is having type 2 disease, he is prone to develop recurrences. I mean, these patients have Semter's triad, right? Many of these patients are having eosinophilia, and they might be having high eosinophil count, total eosinophil, absolute eosinophil count in these patients are very high. So these patients will require long-term steroid spray.
Yeah. So I think the next question has been answered regarding how long to use the steroid spray. Then there's another comment rather. In atrophic rhinitis, sodium biborate along with sodium chloride and sodium bicarbonate was used. Yeah, that was a solution mixed with, I think.
Yes. So that is the classical solution which has been described in our standard textbooks.
Yeah, that's right.
Yeah.
Okay. Thank you, sir.
Okay.
I think that solves
Today's
the
classroom
question.
has extended 13 minutes extended. We usually finish by 9.
So
So
actually,
today it is a good discussion, sir. This is a
so
very good
actually,
discussion.
actually it is a vast topic to be covered in 1 hour. And in fact,
Yes.
I had made lots of questions, but I am going to skip them because of the lack of time, right? But anyway, it was a very nice interaction, and I'm sure people and the residents and the trainees must have benefited from this conversation and this discussion. And thank all the executive members of the NEPCON,
NEBOI.
NEBAOI,
NEBOI, sir.
and thank you very much for the kind invitation.
Can I ask only one question from my
Sir, yes,
side?
most welcome, sir. Sir, please.
Ravi, the thing is that we are getting patient, those who are under hemodialysis, CKD patient, and started bleeding from the nose, right? And definitely the call will come to the ENT, and it is a CKD patient under dialysis.
Right, sir.
Sometimes it becomes difficult for us to control that bleeding.
Absolutely correct, sir.
Right?
Right.
So what we used to do, there is one your one nasal tamponade is there. I think you know that one, rapid rhino.
Sir, Bivona balloons
Rapid,
are there. Yeah, they are.
rapid rhino. Rapid
Yeah,
rhino.
rapid rhino is there. Yes.
Yes,
Rapid
we
rhino.
have seen that rapid rhino, it works in
Beautifully, sir.
majority of the cases.
Yes, sir.
Because there is a gelatin, what you have told earlier. So
Gelatin sponge.
that end will be soaked in water, and after that smoothly it goes, and you can inflate that one according to your need, how much water you want to inject in that way. So initially we used to go for this 10 ml, 15 ml, or at best we go for 20 ml, and we will just uh, keep it for 24 hours. Then you reduce it gradually. You reduce the water, and it gives a good effect.
Tamponade. Yes.
Yeah, because these are the patient, those who are in the under hemodialysis and started bleeding from the nose. Sometimes it becomes very difficult to control that one, because
Absolutely. Absolutely correct, sir.
that is the clinical problem actually we are facing here, and you
Right.
will get it. You will get that area.
Absolutely correct, sir. I mean, these patients are difficult to treat, and I would
Difficult.
advise no touch technique.
No touch
Jitna-
technique.
Don't touch the nasal mucosa.
Yes,
The more you
yes.
touch, the more it is going to
More
bleed.
will
And
be the bleeding.
yes,
Yeah,
and rapid
more will
rhino is definitely one of the good ways to reduce, I mean, decrease or stop bleeding in these patients.
Yes.
But unfortunately, the rapid rhino, I mean, I am working in a government setup, and so we don't have the accessibility to rapid rhino, and it's
Exactly.
very costly affair. But definitely, rapid rhino is one thing which can be used, or otherwise, as I told, I mean, we have been using gelatin sponge to
Gelatin
pack these.
sponge.
Yeah.
Yes.
And sometimes if you have the availability of flow seal, or I mean, sometimes
Sometimes if nothing is there, spongiostin. What you
sponge.
can do?
Yes, the same thing, the gelatin sponge.
Yeah, gelatin sponge. That's
Yes,
all.
or you can actually sometimes use flow seal also. Flow seal is one thing which can
Sometimes
be
even Fisil or Flosil or even using Fibrilla, the one which neurosurgeons use.
fibrillar
Yes.
When I have an odd
Yes.
case or two, we had
Yes.
to send to Kepler for IMAX embolization.
Yes.
If it bleed, you can't see anything. Even if you pack both the anterior and the posterior pack, it doesn't help. I mean, yes, there are some odd cases, but yes, we need to keep all options open. That's what I think.
right, sir.
This discussion may continue.
Yes.
Thank you very
So
much.
today we have
Thank you so much. It's a very good discussion.
Yeah.
It's very good discussion. Everyone has participated. Fantastic.
Yeah, this is the customary to give vote of thanks. So
Yes.
once again, good evening, everyone. On behalf of the Scientific Committee of NEBAOI, I would like to extend our heartfelt gratitude to all who made today's 9th NEBAOI classroom a great success. First and foremost, we express our sincere thanks to our esteemed expert, Dr. Ravi Meher, Director, Professor, and Head Department of ENT MMC, New Delhi, for sharing his invaluable insight and expert guidance on the topic evaluation and imaging of paranasal sinuses. Sir, your presence and academic wisdom greatly enriched this session. Thank you very much, sir. We also convey our deep appreciation to our speaker, Dr. Krishanu Rudrapal, third year PGT, Sikkim Manipal Institute of Medical Sciences, for his excellence and informative presentation. Your effort and clarity in explaining the subject are truly commendable. Thank you, Krishanu. Special thanks to our moderators, Dr. Rupanjita Sangma and Dr. Kaustav Kalita, conducting the session smoothly and keeping the discussion engaging and interactive. Thank you very much, both of you. We are equally grateful to our all NEBOI members, faculty and postgraduate students who joined this classroom and actively participated in the academic session. Once again, thank you everyone and wishing you all a pleasant evening ahead. Thank you very much.
Thank you so much.
Thank you.
Thank you very much.
Thank
and
you
good
very
night.
much.
Thank you, ma'am.
Thank
Thank you,
you.
sir.
Good night.
Hello.
Good night.
Hello.
Anjan,
Can I
you
make
have
an
a
appeal?
meeting.
Yeah. So I was on the way anyway. So
Okay.
now after this
Announcement.
program, Dr. Brian, who is the chairman of our NEBAOI